Now starting. All attendees are in listen-only mode.
Welcome. My name is Meredith Posey. I am a chair for the NASW Committee on Aging along with Angela Zhang, and we are pleased to present Silver Linings, Adapting Community-Based Services to Older Adults During COVID-19. I'd like to thank everyone for being here with us today and put a special thank you out to my co-chair, Angela, as well as all of the Committee on Aging members, Bernie, Allison, Dakota, Anne Marie, and Anna, as well as to our NASW Executive Director, Lynn, and our Chapter Relations and Outreach Coordinator, Tori, who have assisted in both developing the content as well as putting all of the details of this webinar together. I want to thank the NASW members who are joining us today who make events like this possible. And of course, last but not least, thank you to our speakers who are graciously here today sharing their vast knowledge and experience with us. We really appreciate it. So some housekeeping things. You will be muted the entire time. There will be time for questions at the end. You're welcome to put your questions in the chat box. Just make sure you choose all so that they can be seen by everybody. We won't be getting them to them till the end, but you're welcome to put them in at any point along the way. You'll want to make sure that you put your full name in the chat box to get the CEUs, and you also need to remain attentive, with us so that we can give you our CEUs. And you will receive a copy of the slides as well as a resource handout that we've developed after the webinar today. So with that, I'd like to introduce our speakers for today. We have Allison Thieberge, who received her MSW from Salem State University in 2001 with a concentration in older adults. She currently works for Village MD, embedded within primary care practice as a social work care manager. She works in collaboration with a nurse care manager to support patients with chronic illness, behavioral health issues, and substance use disorders within the primary care setting. Prior to her current role, she worked for 15 years as the clinical director at Elder Services of Merrimack Valley, overseeing clinical initiatives and programming, including the Elder Protective Services Program, the Social Work Internship Program, Homeless Outreach, and Community Mental Health Programming. She's a certified master trainer for Connect, a national best practice suicide prevention and post-vention training curriculum, and she's trained in evidence-based programs, including Health Ideas and Impact for Depression Care. Allison Rataj is a project director at the University of New Hampshire Institute for Health Policy and Practice and the UNH Center on Aging and Community Living. She provides assistance in designing, implementing, facilitating, and evaluating grant-funded projects in home and community-based settings. Since joining CACL in 2014, she's worked on a range of projects, including Aging and Disability Resource Center, No Wrong Door System of Access, Balancing Incentive Program, Money Follows the Person, New Hampshire Alliance for Healthy Aging, and the Senior Leadership Alumni Network. She's a second-year PhD student at the University of Massachusetts, Boston, Gerontology Department. She also works part-time at UMass as a research assistant on topics including social isolation and loneliness in later life, grief and bereavement, and marital relationships in older age. Anne Marie Olson Hayward is the director of New Hampshire REAP through Seacoast Mental Health Center, where she is also a therapist. Prior to this, she worked as a therapist at Frisbee Memorial Hospital, Geriatric Psychiatry Department, where she worked with patients and families of individuals with Alzheimer's and other related dementias. Anne Marie is a board member of the New Hampshire NASW, participating in committees and community groups which focus on geriatrics. Her extensive experience includes 15 years of working in an acute and outpatient setting. She's an active participant and one of the founding members of Pathways Through Aging, which focuses on addressing systems gaps for our older populations. She's presented at state and regional-wide conferences on the systems issues which impact people with dementia and their caregivers. She teaches the Savvy Caregiver course for informal caregivers of people with dementia and is a certified dementia practitioner. And last but not least, we have Bernie Seifert, who earned her MSW degree with a subconcentration in aging from Boston University in 1984. She's been a licensed clinical social worker serving older adults and their families in New Hampshire since 1988. She is currently the director of adult programs at NAMI New Hampshire. Over the past several years, she's conducted numerous trainings on topics for varied audiences, including programs focusing on caregiving, dementia, mental health and suicide prevention. She's also the geriatric mental health training coordinator at the Northern New England Geriatric Education Center at the Dartmouth Centers on Health and Aging in Lebanon. Her current affiliations include the Board of Directors at the NASW, the Board of Directors at the New Hampshire chapter of NASW, the New Hampshire Coalition on Substance Abuse, Mental Health and Aging, New Hampshire Coalition on Caring, and the New Hampshire Attorney General's Elderly and Vulnerable Adult Fatality Review Committee. Bernie received the New Hampshire NASW 1996 Social Worker of the Year Award. And with that, I'd like to pass it over to Allison Rataj, who is going to get us started, setting the stage for this presentation. Thank you.
Hi, thank you. Let me just make sure that folks can see my screen, and I will make it large. Great, so thank you so much. Oh no, I just lost my notes. Hold on one moment, please. Having some difficulties. Great. Okay. So, hi again. Formally, my name is Allison Rataj, and I am coming. Oh, I'm trying to navigate this. I am so sorry. Okay. Hi, my name is Allison Rataj. I work at the Center on Aging and Community Living at the University of New Hampshire. And I want to just really, again, briefly thank the New Hampshire NASW chapter for sort of helping the Aging Committee really put together this presentation. I am so thrilled to be here and presenting today, so thank you. And to thank you to all of you that are out there joining us today. So my role is really to set the stage for our panel presentation that will occur in a little while. I'm going to be providing some context and background related to older adults and the COVID-19 crisis. So I'm going to get a little nitty-gritty into some data and statistics on COVID-19 and aging, but I'm going to do it with enthusiasm, so hopefully, hopefully you won't find it too dull. So let's get started here. So we know that when it comes to COVID-19, that some people are at an increased risk. And those people tend to be older adults and people with certain medical conditions. So when we think about aging generally, people who are 60 are at a higher risk to sort of become more ill than somebody who is 50. And somebody who is 70 is at a higher risk to become ill, or in this case, to contract COVID-19 than somebody who is 60. So this is because as we age, our immune systems get weaker. And unfortunately, what that really indicates is that as we age, we're not getting healthier. And as we're not getting healthier, we have these conditions and underlying medical situations that kind of follow us through our life journey, and those are really, you know, those chronic conditions. And so as we see in our data slide here, 80% of people who are 65 plus have at least one chronic condition. 68% of people who are 65 plus have at least two chronic conditions. So when we think about COVID-19, what we do know about it is that the conditions like cancer, kidney disease, COPD, heart conditions, obesity, smoking, and type 2 diabetes have been sufficiently and scientifically proven to being linked as risk factors to COVID. So thinking about, okay, you know, so we're not getting healthier. We're older adults are sort of having those underlying medical conditions follow them. So what does that mean? Well, that means that our older adults are at most risk to contract COVID-19. So let's take a look at what that means for New Hampshire. So we know that our 80 plus category is the most vulnerable, and that's really what these charts are showing. So this chart here on the left-hand side is looking, and so I don't think I put it on here, but this is specific New Hampshire data. So this chart here on the left-hand side is looking at the number of cumulative infections based on age group, and that's the blue bars. So you can see the age ranges here. The orange bar, or the orange line, is really the rate per 100,000 persons. So take the 20 to 29 year range, right? They have the largest number of cumulative infections, but their rate is mediocre. Let's look at our 80 plus population. Their number of cumulative infections is probably somewhere in the middle of this sort of data collection, but literally their rate per 100,000 persons is off the chart. So that's telling us that the rate per 100,000 persons is making people much more vulnerable than our folks who are in this range here. And then something sort of similar along these lines are the graph on the right-hand side is looking at the percentage of total deaths by age. So your eye is kind of immediately drawn to this last bottom bar here. And so what this data is really telling us is that it's saying out of the 400 and some odd, I'm sorry, I don't have the exact number and I'm really bad at math in my head on the fly. So that out of the 400 and some odd people who have died from contracting COVID-19, 292 of them are 80 plus. And that totals 64% out of 100% of deaths. Not surprisingly, the very next category, out of the 400 and some odd people who have died from COVID, 108 of them are in the 70 to 79 category, or 24% out of the total. So we're seeing, you know, an 88%, calculation rate here for people who are 70 plus, that are from the people that have died from COVID, are 70 plus. So what does this mean and how are we gathering our data? So researchers right now are really trying to track what's going on with COVID. So right now they're gathering information, they're analyzing it, they're looking at all of this different type of differences across geographical units, not only nationally, but also here in our state. So in 2019, New Hampshire became one of the 3 states to have a healthy aging data report. So the Healthy Aging Data Report is a product of the University of Massachusetts, Boston, and it is funded through the Tufts Health Plan Foundation. And the Healthy Aging Data Report is a suite of online tools. So if you go onto this website and you navigate around, you'll see some really cool things like infographics and community profiles, interactive state maps, and a whole lot of other cool stuff. And sort of the hallmark of the Healthy Aging data across this huge range, over 150 indicators on categories including behavioral health, chronic disease, service utilization, etc. And the really unique feature about the Healthy Aging Data Report, one reason I absolutely love it, is that it has indicator level data for every city and every town across each of these 3 states. And you can also see that it has statewide level data. So for me, right, I live in Kingston, New Hampshire. I can look at my community's data, and I can compare that with my neighbor, community of Brentwood and look at Brentwood's index level. So I would highly recommend that you go to this website and check out what's available in your community. So through my work at the Center on Aging and Community Living, we were able to commission the Healthy Aging Data Report team to put together some information for New Hampshire level data on the impact of COVID and older adults in our state. So that's what I'm going to talk a little bit about next. So this slide is really showing the number of comorbidities by each town, which is overlaid by the number of COVID cases. So just to kind of walk you through this really quickly, as the shades of orange get darker here, we see that the number of comorbidities increase. So geographically, every single town in New Hampshire, well, except for the ones with the little dashes, which is where the data was not available, we can see sort of the community average of comorbidities for those who are 65 plus. And then the green dots represent the number of COVID-19 cases. So the bigger the dot, the more number the cases within those communities. So one thing that I do want to point out is that this data was analyzed and collected on July 13th, 2020. So that's one of the woes of using data, is that as soon as you report it and as soon as you gather it, it becomes outdated. So I would assume that some of these COVID numbers are probably different, being in October of 2020 today. But really, this graph is just to kind of give you a sense of what are the comorbidities looking like geographically. So in Coos County, we can kind of see that there's a throng here of folks that might have more comorbidities. And maybe, you know, here in this part of Grafton and here in this part of Cheshire. And then you just can see so many green dots are kind of overlaying this part here. But the idea is that when you see sort of areas that have higher comorbidities, thinking about how these specific geographical areas could be more vulnerable to a potential COVID-19 outbreak. So this is a nice segue into my hotspot analysis. So UMass Boston was able to put together a hotspot analysis for us using some statistical analyses. So I am not going to, because of time, I'm not going to walk through all of our different clusters, but what I do want to indicate is that you want to take a look at these kind of pink shaded areas. So what these pink shaded areas are really indicating is that the community, people who have comorbidities are more vulnerable. And if we go back to our first slide, you can kind of see that there's comorbidities here, here, all in here, and that they somewhat overlay. So what the researchers did was they took the amount of comorbidities, they put it into their statistical analysis software, and what it spit out was statistical significant areas where if COVID was potentially to have an outbreak, these areas would most likely be hit very hard. So that's why it's somewhat called a hotspot analysis. So again, if you're interested in the other clusters, I am happy to talk about them offline. So I wanted to take a couple minutes to just talk about the fact that COVID-19 is not hitting everybody equally, and that there are certain populations, especially for Black and Brown people, that there are huge disparities in those numbers. So these graphs are indicating the percentage of the population who are 65 plus that are African American on the left, and on the right, the percentage of the population that are 65 plus that are Hispanic. So the darker the color, the color of the purple, that means that there's a higher percentage within those communities of the specific minorities. And of course, the green bubbles mean that there is an overlap. So I'm sorry, not an overlap, that there's a number of COVID cases. So the reason that I put these up here is that I think that we need to be paying attention to these specific populations because we know that people of color are not able to access medical care as easily as people who are white, do not have the preventative services that they need. And different things like that. So I think that we really need to be paying attention to these disparities. We need to be, as social workers, we need to be thinking about how best we can provide support to these populations, right? So I was thinking about recently, if a person has a specific grocery store that they like to frequent so that they can buy certain types of food, but then perhaps that grocery store closes, due to COVID, or maybe they don't feel like going to that grocery store to get their food that they want due to, you know, it being highly trafficked or things like that, and they can't get their food. Well, you know, what does that mean? And how does that sort of contribute to their nutrition and then their overall well-being and different things like that? So I think that we really need to be paying attention to how we can best support everybody in the community. So at the ACL, we have a technical assistance contract with our ServiceLink resource centers. And for folks that might not be familiar with our ServiceLink resource centers, they are our aging and disability resource network They serve all payers and all populations, but predominantly their clientele is older adults. And they provide a range of services, so things like information and referral. They have caregiving sort of services, as well as, oh goodness, right now it's Medicare open enrollment, I bet. So I'm sure that they're exceedingly busy at the time. So because we have a technical assistance grant with them, we provide a range of services to them, including trainings and providing sort of some financial grant things for them, etc. So as part of our role, we really wanted to know a little bit more about what the ServiceLinks were seeing in relation to barriers and challenges in the community. So we do what universities typically do, and we sent them a survey. And it was in a very open-ended survey where folks had the ability to sort of write in things that they thought were challenging for older adults in the community. And what we really found was that technology was a huge barrier for older adults during the time of COVID. There was a couple of different sort of sub things with technology. The first is related to access. So actually getting broadband was a bit challenging for older adults. So, you know, not only just getting, you know, like having somebody come out and hook up your computer, or getting, you know, actually hooking your house up to broadband. What if you don't have broadband availability? So that was that's been a major barrier for some folks. The second is getting a device. How do you get a device? Where do you get a device? What's the best device to get? So kind of thinking about sort of those aspects. So then another sort of barrier is also using the device. So you now have the device in front of you. How do you use it? How do you turn it on? How do you turn the volume up? How do you put the pin pad in, and all of those kinds of things? And then something else that the survey really showed us was using applications. I guess I hadn't really thought about this particular sort of usage, but you know, when you go to download an app and it asks you for your Apple ID password and you can't remember it like I do, I have to write it down someplace. Do older adults even know what that is? So I apologize. For anyone that has a dog, I'm sure you hopefully haven't had that happen to you before, but so for older adults that need help using applications, the ServiceLinks also told us that they couldn't actually sit with folks. So they couldn't actually show them how to use the specific device itself. They were on the phone trying to walk people through how to use applications and using their devices. So another barrier that the survey really showed us was cost. So, you know, for older adults who are most likely on a fixed income, buying the device will be most likely expensive. How are you going to pay for it? And then also paying for broadband. So you have this, you know, this new sort of access to internet. Well, all of a sudden that becomes a monthly expense. So how are you going to be paying for that as well? And then my last plug, as a researcher who is exceedingly interested in social isolation and loneliness, the survey really identified that people who are socially isolated are at an increased risk for loneliness. And what we know is that loneliness is actually, people who feel lonely have the equivalent of smoking 5 cigarettes a day. So, you know, the survey kind of indicated that maybe technology can help in relation to addressing these barriers of social isolation and loneliness. So this slide is really just, you know, showing us from the Health Aging Data Report, internet use and broadband access. So I just want to kind of give this to you as some context as we're thinking about our presentation later today. So this one here on the left-hand side is really showing who used internet in the last month. So the areas of red are the folks who use the internet the lowest. The salmon color here are folks who used it second to lowest, and then so on and so forth. So you can kind of see Coast County, not a lot of people using the internet, Also on the right-hand side though, these are the folks who have access to broadband, right? Also lowest area with access to broadband. So I would say that that probably plays that these two are interconnected to a certain extent. Also, folks who don't have access to broadband, Cheshire County, very low when it comes to these to access to broadband. So again, these are just kind of things for you to be thinking about as we're moving along through our program today. So telehealth has increased dramatically during our pandemic for obvious reasons. And these graphs are just kind of giving you an idea of the number of medical appointments here on the left and the number of behavioral health appointments here on the right that have been moved to telehealth. So telehealth has really provided ways for people to continue to connect and receive the care that they need, but it's not a magic bullet. And that's really you know, what our panel is going to talk about, the benefits and the challenges. And you know, I'm really excited to kind of hear their thoughts and comments today as our folks on the ground. And with that, I'm going to wrap up. If you have questions, please, I would highly recommend to put them in the chat. Or if folks are interested, you can connect with me offline. Here's my contact information. I hope that there was a nugget of information that you took away from this, aside from my dog having a little barking fit. So thank you so much for your time. And at this point, I'm going to turn it back to Meredith.
Thank you, Allison. So I'm going to give our panelists a moment here to join us. And what we will be doing moving forward is we've identified 3 questions that we want to answer. And so each panelist will get the question, and we'll take, you know, the opportunity to hear the different perspectives and their different experiences. So for this first question, what have been the barriers and the challenges to telehealth? And we'll go ahead and start with Anne Marie today.
Gotta remember to unmute myself, sorry. So my name's Anne Marie. I am the director for the REAP program, but I also see clients at Seacoast Mental Health as well. So I think in both programs, we've certainly seen some shifts in terms of how we're delivering services. I'll talk primarily about REAP, but there are some pieces I'll bring in around the mental health component. One of the biggest things we saw was that clients weren't being seen. And so we, in the REAP program, we really relied very heavily on referrals from community partners, and clients weren't being seen out in the community, or they weren't going to the doctor's office, and they weren't going into the hospital, then we weren't getting the referrals. So we had a pretty significant decrease in referrals, and we had to be very proactive in terms of reaching out to other referral sources that we may not have partnered with in the past that might still be seeing clients in the community. So we were reaching out to the fire departments and the police departments and anyone that was still going out in the community and seeing people. We also had lots of issues that, and I think Allison did a great job around not everyone has access to good phone service or the internet. And that's not just for clients, we were also seeing that with staff. We're a statewide program. So, you know, on the Seacoast here, I've got really great service and I can see people, you know, without any problem. I use Zoom very consistently, but my clinicians up in the North Country certainly have issues with that. So that was certainly a struggle that we were seeing. Hearing impairments, so even if someone does have the phone, not all of my clients could hear very effectively over the phone. So that became a barrier for us. And we also had clinicians who maybe weren't comfortable doing assessments over the phone. It's a different way of engaging with people. You have to use a little bit different skill set. So that was a learning curve for a lot of our clinicians, as well as terms of how do we do this? You know, I'm used to going into their home and seeing their environment and using my eyes and my other senses, and now I have to just do it within a phone session there. And how do I keep someone engaged on the phone if they don't want to talk or aren't comfortable talking on it? We also had issues with clients who had cognitive issues. So again, Allison was talking about not knowing how to use technology. But again, if someone's having cognitive issues, that's an additional barrier. You know, or they may not even remember our appointments. So that was another piece that we ran into. Is we used to just show up at people's homes. We would make an appointment and come in, But then we would run into problems where I would call and no one was picking up, but I knew that this was someone who was self-isolated or social distancing and they should be home. And so then we had to start thinking about, okay, we need to have a secondary contact. Like, who else is there that we can reach out to if we can't get a hold of you? So those are all very important pieces. Our screens that we use on a routine basis, a lot of them aren't set up to be used over the phone. So again, we had to change that workflow. We had really struggled with keeping track of which community agencies were still delivering services and in what format. And then how do we contact them, because they're also doing things through a telehealth format or a remote format. So there were a lot of changes that occurred in those regards. And that also impacted our ability to collaborate, which with the REAP program is a huge component of our program, is our cross collaboration with other providers within the community. And I think the other part too is, clients weren't always accessing services. So it was how do we help support them getting in. So, I had clients who needed to go see the doctor, but they wouldn't go to see the doctor, or they needed to go to the hospital and they wouldn't go to the hospital. And so like today, actually, I was on the phone with someone. I have a client who has some very severe depression and also is having some issues with urinary that I'm really concerned about, a UTI or some significant medical pieces going on. I can't see her. So I'm having to call the primary care office to get an order to then have them go out to assess her within the home. So it just creates this whole other layer of work that we're trying to do just to get our usual job taken care of. So I will cut it there, pass it off.
Thank you so much, Anne Marie. So we'll move on to Allison.
Hi, I'm Allison Thieberge. I'm a clinical social worker, care manager within the medical setting. I'm embedded within a medical practice. So for us, when COVID hit, actually, for the most part, are the patients that I follow, the patients that are on my panel, are those that are falling into that highest risk category. So those are the ones where they weren't coming into the office at all. So their appointments were put off and postponed, and we were scrambling to try to get telehealth visits started. So they did actually get telehealth visits going pretty quickly, and then we ran into the issues around access that have already been discussed. So patients who didn't have the ability to do the telehealth visits, patients who couldn't see or hear. I've done so much troubleshooting, trying to explain to patients how to install, how to get on DoxyMe, how to, enable the microphone, enable, the camera, so that they were able to actually see their providers. So there certainly were a lot of struggles with those telehealth visits. In the beginning, patients weren't coming in at all. They are coming more in now, and we have lots of protocols around access to the office. So now patients, when they are coming into the office, they're sitting in the cars and not coming in until, the room's ready. So people aren't sitting around or any of that kind of stuff in order to try to make people feel as safe as possible. With COVID, a lot of the things that got shut down were all of the preventative things. So, patients were only dealing with acute issues, and we weren't doing any of the preventative, which has issues unto itself when we're not proactively trying to deal or address medical issues going on. And with medical, there's only so much that can be done over a telehealth visit. So there's many times when patients really need to be physically seen by their medical provider, tests that need to be run. So they really need to have that face-to-face with their providers. So that was also an issue. Some of the other things that you don't think of initially, but with COVID, the drug reps stopped coming into our medical practices. And when drug reps stop coming into medical practices, we then don't have samples. So a lot of our patients are the ones that are on the high cost medications that hit the donut hole, that don't have coverage, and now we don't have access to those samples. So we were doing, work behind the scenes, calling, drug reps and seeing if we could access things so that patients have those critical meds that are high cost, so they're not without those medications. Without patients coming into the office, things like their medications can be here. Even say we have, samples, or for the prescription assistance programs, the meds that are delivered right to the office, they're here, but the patients are driving or they're too afraid to come in. So, we've been looking at creative ways, to get those medications to patients. So on porch drop medications to patients who don't feel comfortable or safe, or don't have somebody who's able to come into the office and pick those prescriptions up for them. I think the fear and isolation of COVID has really impacted, I think, particularly this population even more. We're seeing more depression, more anxiety because of the fear that's associated with the pandemic and everything that's going on right now. The patients who were dependent on volunteers for transportation, volunteers for getting groceries, those kinds of things. Most of these volunteers tend to be older adults themselves. So then these people who don't necessarily have a strong informal support network are now without those as well. So doing a lot of sort of creative thinking about where can we access that help and that assistance. And I think one of the other real barriers has been, the quarantining and, our population, this older adult population, tends to be in and out of the hospital more, and all of the isolation and quarantining around that. So I've had patients whose loved ones were in a hospital or a skilled nursing facility, and they weren't able to visit, and all of the increased fear and anxiety that's associated with some of those experiences as well.
Thank you, Allison. And we'll present that question to Bernie. So what are the challenges and barriers that you've experienced?
Thank you. Well, my name is Bernie, and I work at NAMI, New Hampshire, which is the National Alliance on Mental Illness, and also at the Aging Resource Center, which is part of the Dartmouth-Hitchcock program up in Lebanon. So my experience has been, I'm going to give you a little bit on both of these environments. So a lot of what has already been mentioned is something definitely that I have seen. And I think just to point out a few things or highlight a few things in more detail might be that for the NAMI, for instance, at NAMI, we have a lot of support groups that are run by volunteers. We have like 35 plus support groups around the state. And one thing that we've had to do is not only get ourselves ready to do these support groups virtually, but to also train the volunteers who are facilitating these. So it required a lot of that. That was one of the, I wouldn't call it a barrier, but definitely something that we had to work very hard at doing. And currently about 70% of our support groups are now being offered virtually. And what we have found with these is that while the numbers of people attending the support groups has not really changed, the people who are attending has changed, in that before we used to have a much older group of people attending, and now there are some older people attending, but there's a lot more younger family members attending. So what I'm finding is that we're missing some of the older adults around the state who used to attend these support groups and are finding it challenging to do that. The other thing at the Aging Resource Center, where it was kind of a nice warm place for people to come in, we have a nice beautiful environment. People felt, who were feeling isolated, felt like they were getting connected when they went there. There was a lot more social interaction, so that barrier that's been lost. But we've worked really hard to reach out to individuals. And some of the barriers that have already been mentioned in terms of access, if you look at when you get the resource list, one of the resources there is called Understanding Ageism. If you click on that, you'll notice that it's not just age that's a barrier to internet access. That program tells us that 32%, this is across the country, so I would imagine that this is very similar to New Hampshire, but 32% of older adults don't have internet subscriptions. So that right there, you know, almost a third of our people potentially don't have internet. But other risk factors for lack of internet access is 18% of individuals of all ages with annual income of less than 30,000 don't use the internet. And then 24% of all ages who live in rural areas report that they have a major problem in internet access. So if you have an older adult who's living in a rural area, whose annual income is less than 30,000, I mean, that increases the risk of their not having access. So that definitely, living in New Hampshire, there are many areas in New Hampshire that you know, people don't have access. So access is definitely an issue. And even if they do have access, it's the skills or the confidence in using those. And I know that Allison and Anne Marie talked about, and also Allison earlier today, about how we need to help older adults learn how to use the devices. And that is something that we as providers, whether we're medical providers or social service providers or mental health providers, we need to take that initiative and help them over that barrier to learn how to use a program. I know one of the clients that I'd been working with, who has been now attending the support group that we offer virtually, has said that it felt like, you know, the whole saying, you teach a fish, you teach someone to fish and they eat forever. They're able to feed themselves for their lifetime. And she said, when you taught me how to do Zoom, I feel like it's opened up a whole world for me, and that I'm able to use it in many different areas now. So we need to, it's not something that's in our job description, but I think we need to make it, because that is definitely a huge barrier. And sometimes we'll feel like, you know, whether you're a medical provider or a mental health provider, they say we don't have time to do that, and we do need to make time. We do need to cross that barrier. One area too, in terms of the confidence, you know, I knit, and my son was looking at me knitting the other day and said, you know, Mom, how do you do that? And I said, well, you just need to practice. And then the next day I was asking him, how do I get this picture on Facebook, like, and he was just, you know, very quickly did it. And I said, how do you do that? And he said, Mom, you just practice. So I think we need to cross that barrier with older adults and really create an opportunity for them to use their skills.
Thank you, Bernie. So we're going to move on to our second question. And the question is, what have been the successes and the silver linings? And we'll go ahead this time and start with Allison first.
So in terms of successes and silver linings, I think telehealth unto itself has been a huge success and a silver lining for COVID and the pandemic. So for our patients who have struggled to get into the office, we now have eliminated the barrier of transportation. So that has been huge in order to make that connection with primary care and patients. Some of our patients have had the ability to do the telehealth, like the virtual visit with video. They've had friends or family or someone who's been able to assist them, and we still have been able to do just the audio calls. We have had less no-shows for office visits with the ability to have telehealth. We still have, we're moving more and more back towards patients actually coming into the practice instead of having everything telehealth, which is what we did have for a while. So patients are coming back in more often, but we still have a good percentage of telehealth. We recently just had a patient who is unable to get out of the house and needed a face-to-face for Medicare in order to get some needed medical equipment in the house and to get VNA services in. And in the past, that would have been really difficult to try to find a way to get that face-to-face so that we could get those needed services and supports. Now, with the telehealth options, we're able to get that telehealth visit done, get the needed medical equipment ordered, and then get VNA out there to help this, husband and wife with those needs. One of the other, I think, silver linings from my perspective has been it's really helped us to teach people and reinforce with people the appropriate place to get care. So from the medical perspective, oftentimes we have people who don't necessarily call primary care. They're going to go to the emergency room, and they're going to go to an urgent care setting for something that could, and really should be managed within primary care. So because we've had sort of more of that fear associated with those other settings, patients are actually calling us and saying, hey, I'm not feeling well. And we're able to talk that through so that they're not going to that higher level of care, which isn't an appropriate higher level of care and would unnecessarily, expose them to risks potentially. So we have been able to really capitalize on that as well. I think for my patients who have had behavioral health needs, we've been able to get them connected with med management providers, with some clinicians in a way through telehealth that we weren't able to before. So I think that has worked out as well in terms of some of the silver linings. We talked some about the access of Zoom. I've had patients, I particularly have a woman who's caregiver for her husband with Alzheimer's disease, and the caregiver support groups that she wanted to attend were at night. She didn't feel safe driving at night, and she didn't have somebody who was able to care for her husband. So with some Zoom tutorials and education, we were able to get her connected with the group, and now she's going weekly or attending weekly through this group and has really been able to make a connection. So I think for some of our folks who have been able to access that technology, it really has, as I think Bernie said, opened up a whole nother world for them. I think of one patient in particular who used to go to AA meetings in person and always went, but just never really felt that comfortable. When all the AA meetings went to Zoom, he called and was talking to me, and he was so much more comfortable in this setting and felt like he was able to share. So he really, got a lot out of the Zoom, and now he does Zoom meetings. They're all over the world, and he thinks it's fantastic, and it's really opened another a whole avenue of support for him. So there certainly have been some silver linings as well.
Thank you, Allison. That's great. We will next pose the same question to Bernie.
Okay, thank you. So I think a lot of the experience that I've had is very similar to what Allison has expressed, and so I just want to highlight one of the things that's happened at the Aging Resource Center is while people are not able to come in person and continue to be isolated at home, one of the advantages we've had is we've been able to offer some online programming for not only like caregivers or older adults for themselves in terms of educating themselves about their own issues that benefit them, but also we've had some program that has been geared towards people who have dementia, and we find that if we keep those like 45-minute long, that the attention can be kept, and as long as the care partner can help the person get online. And that is a barrier, getting somebody again online, and especially if somebody's got dementia, being able to connect virtually is another challenge. But with a lot of support and a lot of encouragement that can happen. We've had and we've had to change the way we do things, not just in general, but also our job descriptions in a sense. We've had people at the Aging Resource Center who are now working as coach techs part of the time to help people learn how to get on Zoom. And we find, you know, it might take, you know, one session with a younger person, but it might take 3 sessions with an older person, and that's okay because it can happen. So teaching someone to get connected on the internet can not only help them get connected to educational programs at the Aging Resource Center or support groups at the Aging Resource Center, but also with their primary care providers and with their families on the weekends. So that silver lining definitely is there. We have a support group that now meets once a week. We used to meet once every 2 weeks, but we meet once a week because it's virtual. And we felt at the time that this pandemic started that people needed more support and more connections. So we changed it to every week. And the result is that, you know, we had the attendance used to be between 5 and 9 people every other week, and it changed to now we have between 12 and 20 people join every week. And the individuals find a report that it's, you know, even after this pandemic is over, hopefully it will to some degree be over, they said we want to continue doing this online. And so the reasons they say is that they don't have to spend all this time getting ready to go to pack the car. You know, they're already caregivers. They're already spending so much time taking care of somebody else, and to come to a 1.5-hour meeting requires, like, for some of them, a 6-hour block of time, because they're needing to prepare, to get people in the car, to drive, to, you know, to go in, come back. So it's really provided an opportunity for them to get support right in their own home without having to find another caregiver to take their place, or to have to bring their loved one with them and leave them in the weight room and then worry about them when they're in the weight room. It also provides an opportunity. We're finding people who are coming from a longer distance now, even though they don't have to drive. So we have people who are calling in that are 2 or 3 hours away, versus really only meeting the needs of individuals in the immediate area of where the support group is run. And they also feel that if they miss 1 week, they report that they can, you know, they don't have to wait another 2 weeks, so that there's not a month between meetings. It's only 1 week or 2 weeks. That the time span really is very helpful. We've encouraged people to use earphones to help not only with privacy in the home, so that the people in the home can't hear what's being said, but also to help with the audio, and you can control the volume. So we've encouraged people to use earphones for to make it easier for them. And we've also realized that, you know, encouraging people to find resources, and I know that the resource list that we're providing has a lot of different a lot of information that you could reach out to help with your clients if you have older adults that need help getting connected to the internet. And I know that I only have 0 seconds left. I'm gonna let go.
Do you have something else to add before we pass it over to Anne Marie?
No, we're all set.
Okay, awesome. Anne Marie, on to you.
Thank you. Yeah, I think I would just reiterate a lot of what Bernie and Allison had to say. You know, we were really fortunate, actually, in both of my positions, that, you know, REAP is primarily a remote, it's remote work anyways. We're out in the community, we're seeing people. We work off of a website. We really can do our work almost from anywhere, and we do our work from almost anywhere. So for us, in terms of that program, there wasn't a ton that had to be tweaked. I think I got the heads up one day, and I think within a day or two after that, we had a workflow in place, and you know, we had to make some small changes along the way in terms of how we did things. But we were very fortunate in that end, and even in Seacoast, you know, we had things pulled together very quickly, which was wonderful. One of the big things that we did do, and we're not doing this much now, but initially we recognized, you know, like Allison Ritage was saying, that there was social isolation. and that, these are already adults that we're seeing that are very isolated. And, we know how much, socialization is important in terms of our cognitive and mental health. And so we were reaching out on a weekly basis to do check-ins. And, we pretty much gave our clients, our counselors carte blanche and just said, listen, if it's a 15-minute phone call, that's fine. Just make sure they're doing okay, make sure they have food, make sure they have meds, make sure they're feeling okay, see if they can put together a contingency plan for them just to get them through until these other services start to come back in again. And that's what we're starting to see now, is that, there's the socialization that we were offering during that short time period is now being filled by other programs like the Well Connected program through Easter Seal. So we can pull back and do more of our primary role and allow those other programs to come in and offer that support. But initially, it was we had a lot of flexibility that we were able to do that, which was wonderful. I would say the other thing that I've seen a lot is increased family engagement, either because families are now home and, maybe the bad side of not working as much is that you have availability, but also with remote sessions, if I'm doing things by phone or by Zoom, like I have a client that I see weekly, and his daughter zooms in from her workplace, and his care partner zooms in from another room, and he zooms in from another room, and we have a family session together. So that's been really nice to have that increased support within some of these sessions, which has been really nice. And sometimes we even had other professionals come in and engage that way. So there's been a little bit more wiggle room because I don't have to worry about wiggle room in that regard. We've also had some opportunities where our counselors were able to facilitate contact with children. So we had one counselor who went to visit a client and realized that the client didn't have access to technology and that she hadn't seen her daughter in Texas in over a month. And so that counselor was able to use FaceTime on her phone and allowed the client to engage with the daughter in Texas. We were fortunate. We did not stop our services. There were some of our counselors who did have to pull back because of their own comfort level, and we had some clients who didn't want to see us within the home or even at a social distance safety network, but our program never stopped during this time, which I think was huge. And I think the other part that this is really kind of mobilized, because again, we're that statewide program, is it's really shifting us to make sure that we can offer services remotely across the state. So, sometimes we'll have areas of the state that may not have as much coverage as others. And so this is really pushing us to get those remote delivery options for either training, community education sessions, et cetera, put in place so that when we do have those gaps, we can still fulfill that need, without having an interruption or not having that coverage for our clients. And then we're also seeing more collaboration. So part of our funding is also through housing. And so we've actually started doing Zoom housing sessions for technical assistance with the managers across the state. We actually had our first one last week. And it was really important. It was a really great call because these are not clinical, these aren't clinicians, these are housing managers, but they're asked to do a lot of clinical support for their residents. And we had a really wonderful conversation around grief for the counselors or the staff, but also grief in terms of supporting their residents. I think one housing manager said they had 9 deaths of residents in our housing site in the last couple of months, which is a huge amount of people to lose. And so we were able to do some really creative problem solving around how to better support those clients. And we see that same piece in terms of, some of them are saying we have no internet access. And at the same time, I have another housing manager who says, oh yeah, we have Wi-Fi throughout our entire building. So you have these huge discrepancies in terms of that access, but we're now having the conversations. And I think, the issues being raised. And I think we're hearing that across the board. We're hearing more about older adult issues that have been there all along, but it really is it's really getting highlighted now, and it's being talked in a much broader sense. So I really love that that's one of the silver linings that I'm seeing, as well as the increased flexibility in terms of we're not getting pigeonholed into just this one way we can deliver services, that we can start to tailor those services depending on what might be needed for that particular client.
Thank you so much, Anne Marie. So we're going to move on to our final question, which is, what are the lessons learned and what are the things that you don't want to go away? And we'll go ahead and start with Bernie this time.
Okay, thanks. Well, in brief, things we don't that I don't want to go away is I think we're going to need to continue doing stuff online. The support group, for instance, the support groups for both NAMI and with the Aging Resource Center, we have to offer some online groups. I'm not saying that we're only going to do online after this pandemic has moved on, but we need to do a hybrid. So because I think the online stuff is meeting the needs of some people, and we're missing a lot of older adults that really want to continue meeting for loneliness reasons or social isolation is the meeting in person. So doing the hybrid definitely is something we want to keep after all of this. One thing that's been helpful is staff we've been doing a lot of check-ins and huddles, and that has proved to be very positive. And when you work in the office, you spend a lot of time in the kitchen or around the water cooler, but these brief huddles that we offer with staff has really been helpful to keep our focus, but at the same time being able to check in with each other, because as providers of care for older adults, we need to be able to check in and to share. It can be very emotionally impactful, and we need to deal with that. And we need to continue dealing with the social determinants of health that this has merely forced us to finally focus on, and we need to keep working on those and keep addressing the needs of people that are beyond just what's happening in the medical office or in the mental health provider office, but what's happening at home. And we also need to change. Pivot is a word that a lot of us are using these days, and we do need to pivot how we are funding things, what we are funding. And access to internet is something that we need to work on in our rural state, and continue working in that direction. So I think those are the things that I'm hoping we've learned in this process, and I would like for us to continue working on.
Thank you, Bernie. So we will move on to Anne Marie, lessons learned and also the things that you don't want to go away.
There's a laundry list there. I think really just the important pieces is the flexibility that, I think, we've for so long we've kind of pigeonholed and said, well, this is how we deliver services. And we really need to start thinking about having alternative ways that we can engage. I've got clients right now that I'm seeing remotely that if I was only seeing them in person right now would no longer be able to come in and get support from me. And, having that flexibility to be, say, I would love to see you in person if we can, but if not, we can still do things by phone or we can still do things by Zoom. I think really it gives better care, it's more consistent care, and it meets the needs. And I think that's really, especially with this population, it's not about us, it's about them. So how do we deliver things in a way that is approachable and supportive of what they need? And so many older adults, we are a rural state. We don't have a lot of public transportation. And so many of our older adults aren't driving as much, or if they are driving, if they're driving at all. And we have an increasing number of elder orphans who don't have family who can bring them all over the place, or if they do, they're working. So having these alternative ways that we can engage with individuals that don't put an additional burden on them, don't put an additional burden on their family. The other piece I really am loving is using technology for these statewide collaborations. It's so much easier, not that I want to spend all day on Zoom, but being able to set up a Zoom meeting takes a lot less time than trying to set up a statewide meeting with a variety of different colleagues, because we're all coming from different areas, and depending on what the drive is, it could be 2 hours for you and 3 for you and half an hour for me. So it's, I think, having that ability to, you know, set up these remote delivery and really kind of connect in that way is very helpful. And again, I can't stress enough, you know, having the conversations about these older adult issues. It really is just so important. These are not new issues. They've been here, you know, as long as I've been practicing. I think transportation's been, I don't know how many meetings I've been to around transportation since I started working. We still haven't fixed it yet. But I think this is really highlighting what's, you know, some of those issues, and they're being talked about in a different way. And I think I think it's gotten to a point where people are realizing we actually have to do something about it. You know, we've always been a rural state. That hasn't changed. But I think what's changed is, you know, now we're all seeing, oh, wow, that is a problem. So, you know, I want us to continue to have those conversations. I want us to continue to put ourselves in our client's shoes and think about how it is for them. And I think also looking in terms of, I love what Bernie was saying, you know, we're not going to do everything remote, but there are people we were missing when we're only doing things in person. There are people we're missing when we're only doing things remote. There's got to be a better way to bridge that. Thank you.
Excellent. Thank you so much. And Allison.
So I think from my perspective, you know, the access to telehealth visits is huge within medical care. I think that we have gotten much better at being able to figure out which visits are the visits that can be done successfully with telehealth and which visits are the ones where we physically need to get the patient into the office. So if patients have a limited number of resources for medical transportation, they're only gonna, you know, feel comfortable asking that family member every so often to help them get into the office. We're able to take advantage of the fact that they have a ride to get into the office and use that for the visits that they really physically need to be seen in the physical office. And then the other visits, we're able to do the telehealth visits. So I think that's been great. I think one of my lessons learned is, you know, that we certainly are able to teach people how to use this technology when they have it. I can remember a patient that we started with his phone and the DoxyMe, and initially the way he held the phone, I could just see up his nose, and that was it. And now he calls me and I see him and he sees me, and I talk to him on a regular basis, and it's fantastic. He connects with his grandkids this way now. So it's really in terms of connecting that way. I think as a clinician, I have a DoxyMe. I do a lot of my visits this way now, and I can see so much, you know, I mean, just being able to, not that you don't pick up the nuances when you're talking to people, their inflection, their tones, but you can see, you know, you can actually see someone, you can read their body language, you know, I can see their environments of their home, which obviously gives you so much more information in regards to what's going on. I have patients that look forward to that connection every week. So, you know, they are more isolated. They might not have family, but, you know, that 20-minute, you know, virtual visit with me on a weekly basis makes a tremendous amount of difference in terms of their, you know, their isolation and their loneliness, which is fantastic. I think, as we've said, it really has opened up doors for some of our patients in terms of being able to get connected with supports, caregiver groups, grief groups. I have a patient that I'm working with who lost her spouse of 42 years during the pandemic, wasn't able to have any type of real services, and has really had a super hard time with grief. And with some help from her kids, we were able to get her into a spousal, you know, online Zoom support group, which has made a tremendous difference for her. So being able to continue to have, you know, those supports available. I talked before about, you know, the education piece. I think for some of the folks that I work with, you know, there's still this stigma around mental health and depression and anxiety. And this has really provided, you know, the ability to talk about, normalize those experiences, because so many people are dealing with these things within the pandemic. So to be able to have some conversations and not get shut down so quickly when talking about it. And again, you know, the appropriate use of medical care. I mean, we really have come a long way in terms of being able to teach people and reinforce, you know, where you can get medical care and what makes the most sense. And I think we have been forced to think creatively about things. So, you know, to be able to have the patient at home who probably has a urinary tract infection and, you know, we can't get them to where they need to go. Now we're thinking creatively on how do we get the nurse to go there to grab the urine to determine if they have, you know, a UTI. So we use the telehealth visit, you know, to get the VNA out and get the orders. So really a lot of thinking creatively about how to meet people's needs. And I think communities in general have really come together. I mean, there's been lots of, you know, those groups on Facebook and people saying, hey, I can help with that, you know, just in terms of the community really rising and being willing and able to help, you know, people within their community with some of these struggles and difficulties that we're having in terms of accessing care.
Excellent. Thank you so much, Allison. So from here, we're going to move on to questions. So we'll have Allison Rajaj join us back just in the event that any questions specifically are for her. So there she is. Wonderful. So the first question is, what are the resources for getting access for devices, to devices for elders who need to use telehealth? Anyone can jump in. Anyone have?
I can't speak statewide, but I do know, you know, at least for like Seacoast Mental Health, there have been a few devices that have been provided for some of our lower income clients on an as needed basis. Unfortunately, one of the drawbacks is they get the device, which is wonderful, but they only get a coverage, I think, like a couple months, and then they have to continue to pay for it. So I think there's some pocket groups that you can find, you know, where it might be you know, within your, I think it's very much community based, very grassroots, but you know, some of the mental health centers, some of the community areas occasionally have them.
And there are the SafeLink wireless, you know, they're often called Obama phones, or, you know, where people who are of, you know, lower income, who meet the criteria are able to. I've done more applications for those phones since COVID started, and have successfully gotten people, you know, gotten their phones and then been able to work with them to teach them how to use the technology.
I just want to note that, you know, Allison did put those links. We have those links in our reference resource list. So when you get that as a handout, you know, Allison did put those links in there.
So I would also make a mention that AT&NH, which is Assistive Technology in New Hampshire, which is through the Institute on Disability at the University of New Hampshire, also does provide devices, training for those devices. And folks can go to ServiceLink and they can sort of loan a device. So if you have a person who thinks that maybe they want an iPad, they can go to ServiceLink. ServiceLink can loan them the iPad. They can practice at home, and then they can decide whether or not they want to purchase one of those. So I would encourage sort of our audience member to look at AT&NH's website for more information.
Allison, can I ask if, is that all service links, or is that just specific service links, do you know?
Nope, that's all of them. So AT&H is statewide. Thank you. I meant to say that.
Thank you. And that actually segues a little bit into this next question, which was, Allison Rataj mentioned that one of the challenges getting seniors connected to telehealth is that even when they have access to the broadband and may have the means to get a device, there isn't necessarily anyone to teach them. So any other resources that folks are aware of, that are offering to teach folks about the technology?
I know that at the Dartmouth Centers for Health and Aging, we do offer some support for older adults who call in and ask for that type of help. So, and it's done, over the phone. We try really hard to kind of walk them through it. So that is one resource. Call your grandkids.
So I would also say that local libraries are doing a lot of work in relation to providing workshops and things like that for folks.
Good school project for people for high school age. I know we've had at the Aging Resource Center before COVID, we had an arrangement with the local high school where students would volunteer and they'd make appointments with older adults who they would meet at the Aging Resource Center, and the student would be helping the older adult learn how to use their iPhone or their iPad or their laptop. So definitely this is a great idea for a school project.
And they also, there are more and more primary care offices that have social workers now. People don't actually necessarily know that. So it's probably worth asking, because I do a ton of it in terms of helping.
And new scope of service, isn't it? It's like, yeah.
And I'm not seeing any other questions at the moment. Does anybody else want to add some questions into the chat? We'll give you guys a couple minutes to do that.
And while we're waiting, I'll just share a quick story of when we first started doing the support group. One of the highlights for me was we met over the phone with a 90-year-old to try to get him connected to his iPad and getting him connected to the support group. And the first day that he joined the support group, I'll never forget, he was sitting on his couch and he was looking with this big smile, silly gorilla, and he goes, isn't this something? You're all in my living room. Isn't this something? And this guy, continued to meet every week for a long time. And his wife recently did die, but it was just what kept him together. He couldn't wait for that weekly group so he could see everybody. So people can learn.
Yep.
And we need to get beyond that ageism that older people can't do this, because they can.
Thank you for sharing, Bernie. So I'm not seeing any other additional questions. So just a couple of housekeeping things and we'll wrap up a few minutes early, I guess. So I know that there was some questions in here about handouts. We have a PDF of the slides that Allison shared at the beginning, which will be going out to you afterwards. And then we also have a list of various resources that we put together, that might be helpful for you. Certainly, looks like we have another question here. I'll get to that in just a sec. But, so we've got a lot of resources on there, which we hope will be, helpful for you. And just a reminder as well that you will be getting an evaluation form via email also with all of that. So let's see here. There is a question here from Julie that says, regarding REAP, it says, is being able to see a REAP client not happening specific to your agency? She's went out to see a REAP client a few weeks ago. So I think this question is for Anne Marie.
So in terms of not, I guess I'm not understanding the question. So REAP is seeing clients within the community, and we have been all along. There were times when, so we might get a referral and the client may say, you know what, I don't want anyone at my house. Then we would do it remote. Or I might have a clinician who might be at higher risk themselves, because again, you know, aging workforce, and we all have our own health issues. So that clinician may say, you know what, I want to continue to do the work. I can continue to do the work, but I don't want to put myself and my health at risk. I can't go into people's homes. I can't, even with the social distancing, I don't feel comfortable. So that was really a case by case basis. And we always kind of default back to the agency as well. So each agency, all of our REAP counselors are in a community mental health agency in each of the 10 counties. And so sometimes those agencies would put parameters around what they could or could not do. But I don't think we ever had a time when we did not have a REAP counselor out somewhere in the state seeing people face to face. It was intermittent more than anything else.
Excellent, thank you. There's a question here from Leslie. Does anyone know if there's help for clients to afford a vehicle? That's a tough one. Not sure if anyone's aware of it.
Can you ask the question if for clients who what? Who?
To afford resources to help clients afford a vehicle. Yeah.
This conversation the other day, because there are some programs, but a lot of those programs are really focused around, talk about ageism, and maybe not age, but practicality more than anything else, focused on people that are going to work or have young children at home. Those are, and a lot of them have income criteria. You know, in terms of, you know, you have to show that you're earning income from someplace. So there was a program we had out here on the Seacoast that I think folded a few years ago, and we have not seen anything since. So if someone has some information, please share it, because I have 3 clients right now that could use it. But
I would call ServiceLink and ask.
I did hear from someone that at least on the Seacoast, over the border in Maine, there's someone who's selling police vehicles, repurposed police vehicles at a pretty good price, but I have not bought one myself.
And we still have a few more minutes. Any other questions? Again, we can give people a moment to just put them in the chat box.
And Meredith, hi everyone, this is Lynn Stanley at NASW New Hampshire, and thank you all for joining us. And I just wanted to go over one of the logistical pieces around CEUs, because I know we've gotten a couple of questions, and this isn't set up like Zoom where you type your name into your chat. So I have the listing of everybody who's here, and if you put your name into where you ask questions, that's where your name would go. That's very helpful. And that all the handouts will be sent to everybody. Everybody who's here for CEUs will get an evaluation as well. And you'll see where you should be sending it. But please give us a little bit of time, because I need to go through who's for CEUs, who's not for CEUs, and whether or not you showed up in the attendance list. But also, if I can just highlight something that Bernie was saying, we don't often think about high-speed internet as being a social work type of issue, but COVID-19 has really highlighted that high-speed internet and access to devices is an equity issue. It's huge, whether it's for older adults, whether it's for kids who are doing school remotely. We need to be thinking about it as a public utility, much like electricity and water is. 21st century, this is what we're doing, and it is an issue that NASW New Hampshire is absolutely following. So when you see those calls to action, please respond.
All right, Well, thank you so much to everybody for joining us today. And thank you again to our presenters for, such a great amount of information. We've been all just kind of flying by the seat of our pants with this. I mean, I think that there's a lot of us out there that, we're hoping to see telehealth and more options, for remote resources for our patients, but I don't think any of us were expecting to be thrown in quite the way that we were. So, there's always more to learn. And so I'm really grateful to everybody today, for coming out and sharing some of those tidbits and experiences. And also it's really wonderful to hear the positive stories too, and the ways that, we're connecting with people and improving their lives and their well-being during a time when there's so much upheaval and struggle. So thank you for joining us today. If you have any other questions, by all means, you've got Allison's contact, you've got the, contact for the NASW, please feel free to reach out. And thank you so much for joining us today.
A special thank you to Angela Zhang, who's in the background there helping, part of our committee. Thank you.
Thank you. Oh, and I'm sorry, I just want to circle back real quick. I just noticed she sent me a message, Angela did. She said Good News Garage to the question about transportation. So.
There she is.
There she is. We
She's
can't hear
muted.
you.
I'll pop in and mention that really quick if that's okay. So Good News Garage is a nonprofit that we often refer our clients to, and they have lots of different partner garages across the state. So we can send that out in the resource handout too. But they take in donations of cars and they give them out to people. I'm not exactly sure what all the qualifications are, but that's kind of like the best shot that I know of. So
I believe that they're one of the ones where you have to demonstrate that you're working or have a, I think that's one of the ones that they have the criteria, but certainly, maybe if they get enough phone calls, they'll think about expanding that.
Mm-hmm. So anyways, thanks y'all.
Okay, thank you.
Thank you, everybody. Have a great rest of your day.
You too.
Thank you.